That is a kind of a ballroom where the President of the United States of America, they sit when they want to make kind of some decisions. It's a decision-making room. So if they want to go for a war somewhere for some reasons, any reason that needs some very systematic analysis, then they sit in the situation room. So we'll hear about what happens in the situation room of the councils and what they came out and what they've achieved so far. So in this forum, we have 5 people that will present. We'll start with Sister Mary Shadrack. Sister Mary Shadrack is here. The first from your left, she's waving. She's a public health and, specialist with over 20 years working experience in the government sectors. She's coordinating the nursing services at PORAG, Division of Health, Social Health and Nutrition Services. She's also famous in what we call the Macaulay model, the accountability kind of a model that was developed for the purpose of enhancing accountability in our primary care facilities. The next that will be speaking today, we have also James E. Msami. James, can you wave? Yeah, so James is from Temeke Municipal Councils. He's a coordinator for quality improvement and malaria control. So he is also a CHMT member. CHMT is Council's Management Team member since 2013. And the professional, he's a health officer. Another person that is going to speak today also, Frida G. Tesha. Frida, can you wave? She's coming from Dodoma City Council. She's a reproductive and child health coordinator, and she's a CHMT member since 2014. Professional-wise, she's a nursing officer. The other person that is going to speak today is Emmanuel P. Bia. Can you wave? Yeah, so Emmanuel is coming from Kinondoni Municipal Council. He is a district aids and control coordinator. We normally call them DAC, with 1 year experience, and, but he's also very conversant with the government health management information system. The last one, but not least, we have Arnold Festo Nombo. Arnold, can you wave? Also, Arnold is coming from Dodoma, Chamwino District Council. He is a district health management information system and district IDSR focal persons. He's also a CHMT member since 2018. So those are the guys, people that are going to speak to us today. And just for starting, I welcome Sister Mary for just a brief introduction. When we talk about data use and quality improvement, what is it? Karibu.
Thank you, moderator. Yeah, now we are going to see and present about data use and quality improvement initiative. In 2020, PORALG requested assistance from USAID to modify and scale up the quality improvement and quality assurance process that are successful to improve both the staff productivity and quality of health service implemented in Tanzania, Macaulay Health Center, as he said. In 2021, USAID funded Data for Implementation project was engaged to support the scale-up of requesting using the situation room methodology to promote and institutionalize culture of data use and quality improvement at the council level. The initiative is currently now implemented in 9 councils of Dar es Salaam and Dodoma region toward the So this initiative is being implemented in 9 councils in 2 regions, Dar es Salaam and Dodoma, which are Dar es Salaam, Temeke MC, Kinondoni MC, Chamwino DC, Dodoma, Bahi, Mpwapwa, and Kondoa DC, Kongwa also in Dodoma. So the approach has been used in 2 design and implementation phase. So in design phase, using quality improvement methodology to identify problem and solution. In the problem, data review and problem identification were done and focused on quality improvement initiative. So there they're selecting priority indicators and also to analyze interpret the data and agreed on clear annual goals. These are the place where the problem, CHMT, the identification of problem. But also in designing phase, we have solution part where they identify the change idea through driver diagram. And here they can prioritize a change idea to test. So in the designing phase, you can see there the picture where the CHMT will have a training and focusing on 5 whys and using fishbone diagram so that can identify cause and effect analysis. But also in developing solution, they develop and monitor action phase and their implementation change idea through situation action plans, but also the CHMT facilitating weekly situation room meetings. In implementation phase, the CHMT has weekly situation room meeting, and there the council health management team regularly review the council performance on the indicators and review the facility performance to identify which facility are impending in the achievement of the targets. So they evaluate an action plan to assess whether the implemented action were having the intended effect and should be maintained and potentially scaled. Also, regular coaching by data FY and also CHMT team as itself, but plan for monthly data-driven and supportive supervision. So there, they have to identify through data and come up with gap and also plan for supportive supervision. So their supportive supervision were well focused on data and the gaps were there identified during their meeting. So implementation of the data used by QI initiative contributes to the following health system performance in strategic outcome of HSSP5. As we can see on HSSP5, to assess the health services and the quality of healthcare services, but also featuring on presentation from the 4 of the 9 council who will be presenting on situation room methodology. And this will be the Temeke MC, Kinondoni, Dodoma CC, and Chamwino. So the presentation will cover QI initiative in 2 selected technical areas, which are RMNCH and HIV. So from there now, we will be listening from the presenters from the councils, which you can see their improvement during data review on weekly basis at the CHMT. Thank you so much.
Thank you very much. So we can just reserve if we have any question or comments. After all the presentation, then we can ask or comment. Karib, the next.
Thank you. So my name is Dr. Emmanuel Paul Bia. I'll be taking you through the strengthening linkage of women with positive urine pregnancy tests from the laboratory to antenatal care clinic. So as stipulated by the earlier presenter, we at Kinondoni decided to go with this indicator of data. So we reviewed data and problem identification. So during the reproductive maternal neonatal child and health, reproductive maternal neonatal child adolescent health design workshop that was performed in August 2021, we as HMT Kinondoni observed a council performance of 23.5 as of January 2021 through July 2021 was 23.5%. So we as a council set a performance objective of 30% through June 2022 to be tested in 10 facilities as seen. Cause and effect analysis. So at Kinondoni, we checked and we saw that poor screening of eligible women of childbearing age by clinician of health facility caused a low number of urine pregnancy tests, UPT, performed, which consequently caused inadequate linkage of women with positive ANC results, with positive UPT to ANC, as seen in this fishbone structure. So, implemented actions. The first to combat these problems was to promote increasing screening of eligible women of childbearing age by clinician that would combat poor screening of women of childbearing age, and also increase UPT tests and UPT linkage of UPT positive to ANC clinic. That would combat the low UPT test performed that would link from the lab to the ANC clinic. So we could see a picture of an example of supportive supervision conducted to promote increased screening of eligible women of childbearing age. So, improvement of documentation, we took an example of Kijitonyama dispensary. We saw from the run chart, the green one that we see here, we saw an increase in percentage of UBT women positive linked to ANC from 64% in July 2021 to 100% in December 2021. So we could see this run chart as of Kijitonyama dispensary. Also, we compared the bars. So I stipulated area that we started this, implementing this in July. So we could see from July the bars. So firstly, I could describe them. The blue one was total UPT tested. The green one was UPT positive. Also the yellow one was total ANC linked. Also the other one was total first ANC before 12 weeks. The other blue one, run chart, was UPT positivity rate. The other one was, the green one was UPT, percentage of UPT positive linked to ANC. So we could see the bars, excuse me, I'll show you through here. So the bars from July through August, we could see total UPT tested versus total positive UPT, the bars were a little bit low. And also the link to ANC versus the total ANC before 12 weeks was a little bit low from July through September. But when we started implementing this change idea, we could see tests performed were high versus also linkage was also high. Also early booking was also increased. Also, we could see these run charts. At first, there was a gap. But through October, there was a slight merging of the two run charts. That is, we saw that as we implemented this idea, that those who tested positive were linked to ANC. So this helped us a lot. So, as stipulated also earlier, that we in collaboration with that FY, we saw that in the 10 facilities that were supported, we saw at first they are performing very well through July, but we saw a significant rise from November 2021 through June 2022. This was a really good improvement, and it helped us in making good decisions. So we compared the 10 facilities with other facilities. The 10 facilities did better compared to the other facility and all facilities in the council. So this is just a time frame of when the change idea was introduced in the council versus after the implementation. So as I said earlier, we had a target of 30%, and from workshop design, which was on August 2021, and when we started supporting 10 facilities, we saw a rise in performance. And also, we also had a median of, before, we had a median of 22.5, and later on, after the implementation of the change idea, we had a median of 31%. So this is an impact of early ANC booking in all facilities in Kinondoni after introducing the change idea. So what we did at Kinondoni should be sustained. So what did we do? The change idea, of course, was well received and should be maintained. Also, Kinondoni is working so that the strategy is continued and routinely done to promote data use and data use at the health facilities. Also, we developed a data collection form that will collect weekly data from the lab and the ANC clinic regarding UPT positive clients. Also, another innovation that we have done is we have already sent letters. As of January 2022, we have already sent letters to private facilities and the rest of the council facilities to encourage increased screening, to encourage increased women, eligible women of childbearing age to screening and UPT positive linkage to ANC. Also, information education materials, leaflets are also to be distributed and disseminated to pharmacies that sell UPT tests and also private laboratories. Thank you.
Thank you very much. So go to the next example, Karib.
Good evening. I'm Arnold Inombo from Chamwino, DC, and I will pass you through improving early ANC clinic booking using QI approach in Chamwino, DC. Chamwino, DC is one of the council which implement QI initiatives in order to improve health. And we implement 3 QI indicators, but this presentation will provide what Chamwino is doing to reinforce the implementation of Health Strategic Sector Plan 5, focused on the efforts to improve ANC services through early ANC booking. In Chamwino, DC, first we done a workshop, data review, and problem identification, and we revealed that in July 2021, we had 46.1% of pregnant women attending first ANC visit before 12 weeks. And the national target was 60% by the end of 2024. So first we use a QI tool, which is driver diagram, and CHMT of Chamwino, we agreed that we should increase the percentage of pregnant women attending first ANC before 12 weeks from 46.1 to 60% by the end of July 2022. We done a cause and effect analysis, and we revealed that we had some issues which hinders that good performance of ANC before 12 weeks. First was low awareness of the community on the importance of early ANC attendance. Second, uncoordinated supportive supervision visit, which are not data-driven with inadequate follow-up. Third was low awareness of healthcare provider on the importance of early ANC services, and also was suboptimal identification, registration of pregnant women at the facility, and inadequate data review by CHMT. After I revealed the cause which, after reveal that causes, we propose an action which were implemented. First was a weekly data review by CHMT through situational room. Second, to link all UPT positive to ANC soon after lab result. And third was improve supportive supervision by providing a focused data-driven supportive supervision with a QI coaching on performance monitoring technique. As we see before, we had a problem of doing supervision which are not data-driven. So we implement this in order to overcome that situation. And fourth was a follow-up of action item after supportive supervision by whole CHMT team to ensure are done accordingly. And conducting and monitor outreach services and their contribution to increase early ANC booking. And also monitor community ANC health education session provided by community health workers. This is a trend of percentage of pregnant women attending first ANC visit before 12 weeks of gestational age in Chamwino, DC. As we see, in August 2021, the designed workshop were done. And from that, we see the upward trend of the graph. And in December 2021, we started supporting 10 facilities. And the 10 facility, majority were of the low volume sites. In March 2022, we expanded other 10 facilities, and this was of high volume facilities, and make the total of 20. And in March 2022, we add up 10 facilities of high volume also, and make up total of 30 facilities. As we see, from March 2022, we had upward trend above the target of 60%. This also shows the trend of early ANC booking. From January 2021 to July 2021, we had the median of 46.1, and from the August 2021, where the designed workshop started, until August 2022, we had the median of 54.4%. So we can compare this and so that after design workshop up to date, we had an increase in percentage of early ANC booking. To sustain, CHMT will continue to implement all 6 change ideas and include in their routine ANC activities. Thank you.
Asante sana. Thank you very much. So we continue the next 2. Karibu. So just reserve your question. If you have any comment, we'll have that time.
Thank you, moderator. Good evening, ladies and gentlemen. My name is Frida Tesha, CHMT representative from Dodoma City Council. I will going to present the topic concern of using quality improvement approach to improve the quality of viral load data. Here we conduct data review and the problem identification regarding the data viral implementation. So during the HVLO cycle design workshop supported by Data for Implementation, In May 2022, the CHMT observed data quality issues with the council performance of the indicator, which is percent of women with viral load suppression less than 50 copies per mil. Then the CHMT, in collaboration with facility representative, had discussion on challenges and the possible root cause and developed an action plan. As we have seen, we have targets of 95% when it reaches the June 2023, but our baseline data is 26.9% in the March. So we have the problem of documentation of data, and this is a reason because we was used the old version of PMTST HMS tool. So you can see the from April 2021 up to January 2022, there was no data. Then we conducted the root cause and challenge idea. We have two main root cause we have seen. One is data completeness issue, and the second one, data quality issues. In the data completeness issues, due to lack of knowledge and the new PMTST tools, and the report to both facility health provider and the CHMT members. And the second one is data quality issues, which is due to shortage of registers and the reporting new PMTST tools to some of facilities, causing the facilities to not be able to report monthly PMTST data. Yeah, then we have implemented actions. We have two. The first one, data quality issues, and the second, other identified causes. In the data quality issues, we have two activity or action. The first one, orientation of new PMTST tools, that is MC cohort and the reporting tools. And the second one, distribution of guideline registers and other new HMS PMTST tools to health facility. And in the other identified causes, we have three activities. The first one, facilitate continued availability of enhancing adherence counseling services. Second, improve index testing by conducting mentorship to healthcare workers on tracing elicited contact. And the last, orientation and the distribution of HVLO testing algorithm for pregnancy and breastfeeding mothers. Those are about activities. In the improvement documentation, which is HVLO suppression performance progress, we can see the percentage of PMTST women with viral load suppression increasing. As I have said that our database, we have 26.9 on March 2022, and in July, we have 76.3. So we have some improvement due to documentation of the data. Our aim statements or goals is to increase percentage of women with viral load suppression with less than 50 copies per mil from 26.9 March 2022 to 95 by June 2023. So in order to achieve this, we have sustained action. The action, we continuing ongoing initiative, as I have mentioned, but also we have challenge, which is ongoing training in the PMTST reporting tools, MC cohort and data interpretation to healthcare workers and CHMT members. Also, we have Way Forward, which is to continue requesting training support to healthcare provider on new PMTC tools from implementing partner. Thank you for listening. I welcome my colleague to continue.
Thank you, Mr. Moderator. Good evening, all. My name is James Msami. I'm here to present on behalf of Dr. Chipata, who is today has got the family problem. So I'm going to present on behalf of him. Our topic is improving the proportion of viral suppressed pregnant and breastfeeding women in Temeke Municipal Council. Temeke, like other municipal council, other councils, we started by analyzing data around the proportion of HIV positive pregnant and breastfeeding women in the PMTCT programs who are viral suppressed under 50 copies per mil in April 2022. After doing analysis, we recognized that there was no any data which attained the 95% suppression goal over the 12 past months. As we can see there in our chart, the graph, from April up to March 2022, there was no any data which is reached to target of 95%. So we found this is a problem. Also, in the facility, 57 facilities which we have under these programs or produce services of PMTCT, we found that 50%, around 27, 26 health facilities had got the quality issues, quality data issues, which is completeness or accuracy. Sometimes we can find healthcare providers are just filling the register, but not complete. Or they just enter in the DHS2, but no accuracy. So that was the problem. So we go and find the cause and the effect analysis. We used this fish-bone analysis, and we found there is a data quality issues in two ways. First one, inadequate knowledge on tools. Also, there was improper documentation and incomplete data entry. Also, we found poor adherence to treatment plan by client and in comprehensive counseling. And finally, also we found that there are insufficient oversighting. But to start with, we started with these issues, data quality issues, and this one, insufficient oversight, which involved so much the CHMT team that has the task of just to oversight, but there was insufficient knowledge on doing this. So directly, we started implementation action. And because already we have the gap to, from the CHMT members, so all CHMT members were oriented on MC cohort tools. That is the register and the other document. In guideline specify the process and the timeline for viral load testing, how to fill the MC cohort register, and also practically, we went practically just to practice how to enter data in the MC cohort register and the report book. After that, after doing that, now CHMT engaged the health facility, healthcare providers through supportive supervision and meeting just to conduct mentoring and coaching them on cohort register and the report books, documentation, data entry, and the other data check. The third one, in implemented actions, also we involved so much other implementing partner. In this case was MDH, who supported very much to conduct the refresher training in our facility staff. Now, after doing those things here, we can see improvement as we can see in this graph here. You can see when we started on April 2022, when we intervened 2022, where the suppression was 72.1, but only 1 month, after 1 month of just improving in knowledge on tools, improving in documentations, after improving on data entry. You can see there the suppression or the data goes up to almost to the target. And continue just to sustain from May up to now. The data just as you can see there. Now we are just working to sustain performance above 95% in all cohorts which we have. Now, as the municipal council, we have sustained action. So we don't like it again to drop or to go back where we are. Now we want to move forward. So we have sustained action. One is mentorship and coaching with integrated of PMCTC indicators in routine supervisions. Second, we continue to have a meeting in situation room weekly to have data review and monthly supervision visit. Every Friday in our side, every Friday Temeke, we have situation room meeting. So there, we are just doing data review, one health facility by another, just to see which facility is going or is not working properly, and cause and it give us maybe to drop under 95%. So we go and make corrections. And also, as I said, every month we have supervision, so we conduct coaching and mentorship to the health facilities. That is all, Mr. Moderator. Thank you all.
Thank you very much for the presentation. So that was voices from the councils. Just we go to the phase of Q&A and comments, I welcome Sister Mary for just a brief wrap-up, and then we can go to that phase. Karibu.
Thank you, moderator. Niseme tu kidogo kuhusu hizi council, jinsi ambavyo zimefanya kazi. Sisi kama TAMISEMI tulikuja kuona kwamba tuna takwimu nyingi sana ambazo zipo kwenye system, na kitu ambacho tuna miss ni matumizi ya zile takwimu. So commitment to weekly data review and action plan implementation has the ability to improve performance across the health indicators. Kama tujuavyo, sisi kila mratibu anaweza akawa na takwimu zake, lakini kwa kufanya hivi ambavyo tumefanya kupitia data FI, tumeweza kuiweka CHMT kuwa pamoja, wakakaa na kwenye situation rooms. Hizo situation rooms ukiziangalia data FI walitusupport, wakaweka viti, wakaweka screen, lakini pia wakawawezesha CHMT kuweza kukaa pamoja, kila mmoja kwa eneo lake, kuweza kusummarize gaps ziko wapi, and then they sit together, wanazidiscuss pamoja na kuweza kuweka action plan pamoja. But also data review in more effective if analysis are prepared in advance. Stakeholders engaged in root cause analysis and collaborative problem solving. Kwa hiyo kama CHMT for sustainability, wao wenyewe wakiweza kujua shida ambazo zipo kupitia takwimu zetu tulizo nazo, wanaweza hata supportive supervision zikawa ziko well focused kwa sababu they are using their data ambazo zipo kwenye system. But also evaluation action plan to assess whether the implementation action we are having and the intended effect and should be maintained and potentially scaled. Kwa hiyo tumeona vitu vingi kupitia hizo presentation, siwezi kusema mengi zaidi, lakini huu ni mfano tu wa hizi CHMT ambapo walikaa wote pamoja. Kwa kawaida ukiangalia tulikuwa tukifanya kila mmoja na mratibu na kazi yake, lakini hii kitu imetuweka as a team kufanya kazi na kuchambua takwimu area moja na kuidiscuss wote kwa pamoja na kukama hapo na conclusion. Kwa hiyo kwa kupitia hii situation room data analysis meeting, na inakuwa every weekly, ukisubiri mpaka kota ipite, hapa katikati takwimu zinakuaga zinabadilika, wenzetu mnafahamu na wote tunafahamu. Lakini kwa kustrengthen system yenyewe ikawa inafanya tathmini weekly, ni rahisi kucorrect kama kuna jambo lolote kabla ya kusubiri quarterly meeting mwanze kudiscuss hizo takwimu. Kwa hiyo PORALG kushirikiana na wadau wetu hao, tumeona kwamba hili jambo tukilisustain tunaweza tukayaishi hizi takwimu na tukaweza kubadilisha quality of care kupitia takwimu zetu ambazo tunazikusanya kila wakati. Na kitu kingine ambacho tunakifanya kama TAMISEMI ni kuhakikisha mmewapa indicator CHMT au RHMT. Ukiwapa hizo indicator nini cha kufanya na ukawaomba kwamba naomba nipate taarifa hii na hii, automatically CHMT na RHMT watatumia takwimu kwa sababu wewe kama kiongozi umewataka wafanye kitu fulani, na hiyo itakuwa ni sustainable kwa ajili ya siku ambazo zinakuja. Kwa hiyo sisi tunashauri sana, na hiki kitu kama tunaweza tukaendelea nacho kitatusaidia sana kuliko kuwa na benki ya takwimu ambazo ukizigeuza tunaweza tukasema sisi ni matajiri sana. Lakini utajiri wetu kama tutatumia takwimu vizuri kwa ajili ya kuboresha huduma za afya, hapo ndipo umuhimu wa data ambazo tunazitunza zinaweza zikatusaidia. Asante sana, moderator.
Thank you very much for that wrap up. A round of applause for all the presenters. Again, a round of applause. So that was all about data used for decision making. You cannot measure something that you cannot measure. Yeah? But measurement involves numbers. And when we talk about numbers, you can remember our days in primary school, some of us. Now, welcome for Q&A or any comments. You can just, so this is number 1, number 2 there, number 3, number 4, number 5, number 6. Oh, we have 6 people. Number 1, welcome. So you can just note and then we'll respond accordingly. Number 1, Karim.
Asante sana. So my name is Machumi, I'm with MDH. Thank you, PORALG, for preparing this forum, particularly on the data use and quality improvement. I have just a few, not really questions, but things that I think we can continue to think through. In particular, targeting my friend from Temeke and from Dodoma who presented on the viral load among pregnant women. So thanks a lot. This is an area of interest, and we also had a forum looking at areas around that. But one of the things that I noted, not only in your presentation, but in others, on the fishbone analysis, looking at the root cause, I think there is one component that's missing. Yes, inadequate documentation, we know that is common in our facilities, but there are some other root causes that goes beyond that. For example, competing priorities is one case, is one issue that affects providers at PMTST facilities or ANC at RAD. You have a nurse working, maybe 1 or 2 or 3 nurses, saving 100, 150 grants per day. And that becomes a challenge because they do prioritize doing recording rather, they do prioritize providing services rather than doing recording. So I thought that your root cause, your fishbone analysis missed that important component. You may see improvement because you have gone for supervision, but if that is not addressed, maybe we may not address the main root cause. The other thing is, the other question is for PORALG officials who may be here. My understanding is, as a country, there are some concerted efforts to implement the unified community system, which has the ANC and PMTST component, and I think it's being piloted now. So how is PORALG poised to support that? Because I understand that there are different partners who are supporting, but it's very, it'd be good to hear from PORALG, and as a country, how we positioning ourselves to support that, because electronizing a lot of processes around ANCs is critical in resolving some of these gaps. So instead of somebody kuandika kwenye MC cohort, nadhani wengi wanazijua ni vitabu vikubwa sana. Kule kwenye nani wanavita mikeka, yani ukivitaandika vile vitatu unaweza ukalala kabisa ukasinzia. So maybe supporting electronization of these registers too is something that can help us as partners to improve the quality of information. Not the quality, but the availability, analysis, and use. Thank you.
Thank you very much. Number 2. Our number 2 is there.
Okay, thank you so much. I would like to congratulate all the presenters for the very good work they have presented. I'm Viola, also from MDH. Mine is, I want to add on to the first, to the Dr. Machumi's comment with regards to the fishbone analysis that you have been doing with regards to the ANC, early booking. To my little understanding, maybe you may correct me, we have also issues with the card that, the clinic card that the pregnant women are using when they visit the clinic. I know it has like 6 or 8, I think 6 visits. Maybe, I don't know if we have looked to that, maybe if because they have only 6 visit position to fill in, that's the reason why maybe nurses, they think that pregnant women, maybe they should start clinic maybe at second trimester. I think that's the area also we can look at. Thank you.
Thank you very much for that. More for a comment, and then I think they will respond accordingly. Number 3. Our number 3 was there. Let's finish the first round. Number 3 was somewhere there. It was mixed. It was number 2, but come, can just say something.
Yeah, I'm Frank Musa from Afya Intelligence. I have one comment concerning that data use and quality of improvement for healthcare. So if there is available systems that use it to collect and to store data, how can we integrate this existing system with a social common platform such as WhatsApp and Telegram to make sure that those healthcare providers and other healthcare stakeholders can engage in ensuring that they are overseeing the flow of data from the beginning to the end, so that the decision-making in healthcare can be simplified. How can we apply this existing system within our available system, so that to simplify the availability of this data to all healthcare stakeholders, and not to involve only a few members that are involved in this data? Thank you.
Thank you very much. Number 3, then we had others. The first round was number 4. Come, number 4 is here.
Thank you very much. First, I want just to congratulate the presenters for presenting how they have been using data in improving services in the facilities. This is actually good because they are the CHMTs, they are working in the facilities, and not the implementing partners. So the fact that you have taken the activity by yourself and you are leading, reviewing the data and understanding how it is, it may help in changing the services that you're providing. That actually is very nice. But I just have some few comments or questions, you can call them questions. One, for the LNC booking, I saw one of the change that was appearing in your run chart was the increase in number of facilities. So the same change at some point has led to improvement, and at some point the same change has led to decrease in the early booking at ANC. So I just wanted to understand, are there any other issues that are affecting that, or because it can't be the same change and then bringing different outcomes? So that is one. And to those who presented on viral suppression, yes, this is a very important topic and is a topic of interest. But the changes that you have observed, or applied, seems to be more on documentation, which I'm getting difficult into linking that documentation and viral suppression. was there any other factor? Like, for example, you were observing other women were not taking ARVs correctly, or issues like that that are leading to low uptake of medication that might have led into viral suppression other than documentation issues. Thank you.
Thank you. It's coming again. That one need to think more deeper. Number 5. We had number 5 initially. Number 5. Give the mic to number 5.
Okay. Thank you. I have one comment and probably one question. A comment is, it seems most of the challenges that have been highlighted are in the context of either data quality or completeness. And probably this has been attributed by the way that the data are being entered in our health facilities. Sometimes you find there are a lot of entries that a healthcare provider has to do at the very short of time with a very large number of patients to attend. So probably if we might have thought of digitizing our systems to allow them instead of having different 3 books, probably we can have a single system incorporating all the entries that are required. But my question is, sisters already said that data is very important because it provides a lot of insights in decision making. And according to currently statistics, I was just reading some days back, 80% of hospital-generated data remains unstructured. We are only able to utilize probably only 20% of them. And probably this is due to the way the modalities and the kind of technologies that we are using to analyze data. Currently, the world is moving from traditional data analysis to data analytics, and even they have gone further to big data analytics. And this requires some professional resources such as health data science and data engineering, which are not probably offered in most of our universities. Now, my question is, according to your experience, how can these technologies be utilized at the lower level facilities so that we can improve the extraction of insights from the data that we generate?
Thank you for the comment. Then we'll have the last one, the number 6, because the guests of 1 have already arrived, so we just have to finalize. The number 6 was there. The last number 6. We're not taking the new because of the time. Unfortunately, if you have any question, then you can just come and discuss with us. So we had the number 6, the last one. He was here. We give him the opportunity.
Good evening, everyone. My name is Vincent from MDH. I just congratulate all the presenters for the good topic. And as we know, data is everything. Data is our driver to success and planning. So in this presentation, I just have some few comments and some few questions. To Dr. Bia, he was just talking about early booking and the issue of UPT testing. I think, do we have a plan to do screening for women of childbearing age in community, as we want them to be early in their clinic? So is there any plan that will help us to capture all those women and be attending to clinic, as we, if we just have strategies in facilities and just waiting for them to come might be late than those 12 weeks. But also, I'm part of PHLV, Women and PMTCT. We are just talking about issues of viral suppression coverage to Dr. Dada Frida. So we have a practice of just identifying those clients eligible, and we know that all pregnant women and breastfeeding women should be taking their viral. So what the per guidelines, what the best practice that we can enforce so that as we talk about data, we can't have data in our systems we have or databases without have been documented in the resources document. So what are the best practice that you can implement so that in that process of data reviewing, we have all the data being entered into the database so that the system or the processes of identifying and taking their viral load being consistent. The last one to Mr. Msami about HIV suppression. As we know, we have those sessions, EAC sessions, for the clients with high viral load. And in terms of data, we might say have not suppressed, yes, but do we have, it might be not in terms of issue of data, but our aim is just to make them suppress. So what are the initiatives we have to ensure those sessions are being conducted by our service providers so that we will help our clients to have a suppressed and have a quality service. Thank you.
Thank you very much. I think I should give you the opportunity, just in short, if you had something to say. It's fine? Yeah. Then we have responses from colleague. We start from here. Just very short and brief. The other issues we can just discuss after the session.
Asante. Naomba niongee kwa Kiswahili kidogo ili ni tueleweke. Kuna swali la kadi ya kliniki. Sasa katika hii sehemu ya kadi ya kliniki tulikuwa tunadiscuss pia na Mama Mary hapa kwamba lazima katika hii swala la data use, ndio maana tunakuja kutumia sasa data use. Kwa maana kwamba tutaweka changes katika hizi visits. Kwa maana kwamba hapa tutataka early booking, si ndio? Kwa hiyo maana kama tutataka early booking lazima tutaongeza sehemu kule kwenye card, lakini pia hata kwenye register. Kwa hiyo hizi ni innovations ambazo tunazifanya kwa kutumia hii data use. Swali lingine lilikuwa changes za run chart. Boss. Issue ya run chart ziko mbili. Kuna run chart ya kama nitakuwa nimelipata swali lako vizuri, kuna run chart ya 10 facilities versus run chart ya all concept facilities. Kwa maana ya kwamba ukiangalia hii run chart ya kwanza ya 10 facilities ilikuwa ina kwanza ilikuwa ina performance nzuri kabla, lakini iliendelea kuwa nzuri zaidi baada ya kufanya ile practice ile change idea. Kwa maana ya kwamba zile 10 facilities tulizisimamia vizuri, zikafanya vizuri. Na ile ya pili ambayo ikatupa sasa target yetu ya 30% at the council kama tulivyoiona pale. Kwa hiyo ndo tulivyofanya ile change idea from August I think through June 2022, ndo maana ukaona zile target tukaipata pale. Na swali lingine hili lilikuwa kuhusu screening ya women of childbearing age katika community level. Of course, nadhani katika presentation ilinipita kidogo, lakini hii tunafanya. Kinondoni tunafanya na CHW are well involved katika hili, na ndio maana wana contribute katika hizo graph ambazo unaziona hapo. Kwa sababu ukitegemea tu facility hutapata exact matokeo ambayo unayahitaji. Kwa hiyo hata community pia tunawa involve. Asante.
Thank you. The next.
Asante.
Then Sister Mary will finalize.
Na kwa kuongezea ni kwamba hizi QI initiatives zilianza kuwa implemented kwenye facilities chache, lakini performance inapimwa kwa wilaya nzima, kwa maana kwamba including zile facility ambazo hazikuwa zina implement QI initiatives. Na ndio maana as time being tunaendelea kuscale up facilities ili mwisho wa siku kutokana na yale mazuri, ile performance nzuri ambayo imepatikana kwenye facilities chache iweze kupatikana kwenye facilities zote, kwa sababu sasa facilities zote zitakuwa zina implement hizi QI initiatives. Kwa hiyo tunaendelea kufanya scale up ili facility zote ziweze kuimplement QI initiatives. Asante.
Thank you. Give the mic to the next.
Yeah, kwa Dodoma Jiji nimeona kwamba tumeulizwa best practice ambao tunaweza tukafanya ili tuweze kuwa capture wale akina mama ambao wananyonyesha lakini wajawazito kwa ajili ya kupima hii viral load, tuangalie kama wamesuppress. Yeah, Dodoma Jiji tunafanya supportive supervision ya kila mwezi kwenye vituo vyetu, lakini kwenye kitu ambacho tuna wa capacity wale healthcare workers kwa identify wale ambao ni eligible na kuwawekea sticker kwamba huyu hapa kama hajaja sasa na kumtambua kiurahisi, tunamtambua kupitia ile sticker ili tuweze kumfanyia follow up. Lakini kingine kama hajaweza kufika kwa ajili ya kuchukuliwa kipimo, tunatumia CHW kwenda kwa trace ili waweze kuja kwa ajili ya kufanyiwa kipimo. Lakini bado tunaendelea kufanya session kwa ajili ya adherence ili waweze kusuppress. Lakini ukiangalia presentation ambayo nimepresent, nimelenga uwepo wa takwimu na sio kwenye kusuppress pase, kwa sababu kusuppress hapa tumepima kwa miezi 6 ambapo utakuta bado hatujaweza kupata matokeo. Kwa hiyo kwa sababu ilionyesha kwamba tulikuwa hatuna data kama nilivyoonyesha kuanzia mwaka jana kipindi cha Aprili 2021 kulikuwa hatuna data, na reason nimesema kwamba tulikuwa tunatumia old version ya MC cohort. Kwa hiyo baada ya kugundua kwamba tuko nyuma kwenye old version, ndio tukapata sasa mdau kupitia PORALG wakatusupport, tukaweza kuanza sasa kutumia hii new version. Kwa hiyo cha kwanza ambacho tunadili nacho sasa kwanza ni uwepo wa takwimu ambazo ndio tumeona zimeanza kuwepo kwa capacity wale healthcare workers, kwa kuwafanyia orientation na documentation. Then phase hii tunaofuata sasa hiyo ya kufanya support supervision ni kuangalia walio suppress katika wale ambao sasa tayari tunawapata na kwa document. Kwa hiyo issue nzima ambayo nimeipresent ni all about the documentation ya hawa wateja wetu ambao wana viral load.
Thank you very much. Then in brief, James, welcome.
Asante. Mimi naomba nirespondi kwenye issue ya root cause nyingine zaidi ya documentation kama alivyouliza muulizaji. Ni kweli root cause zote nyingine tuliziona, na sema tu kwenye presentation zetu hatukuziweka kwa sababu sisi tulianza kuzifanyia kazi hizi ambazo zinahusiana na data, kwa sababu bila ya data hatuwezi kuona uhalisia wa improvement yenyewe ilivyokuwa. Kwa hiyo ni lazima tuanze kuweka data zetu sawa sawa, alafu tuendelee na other areas. Lakini root cause hizo pia tumezifahamu, lakini hatukuziweka tu kwenye presentation. Ni hilo tu.
Thank you very much, Sister Mary. Just wrap up and brief. The final words.
Kwanza nishukuru sana kwa ajili ya hizo inputs, zingine tumezipokea, lakini kikubwa hapa tulichotaka kuonyesha ni kwamba uwezekano wa CHMT kukaa pamoja na kufanya analysis. Tumeona hapa wamefanya weekly, na ndipo walipogundua kuna mahali data haziingizwi. Kwa hiyo tuki-strengthen system itself to work, ina maana kuna mambo mengi ambayo yatatusaidia kama nchi, lakini pia yataweza kutusaidia tuweze kufikia hizo huduma bora. Wito wetu ni kwamba sisi kama implementers, tunachofanya hapa hatuji na standard nyingine mpya, ila tunajaribu kuangalia kwamba tayari tuna takwimu. Kumbukeni tulikuwa tuko timely reporting and completeness. Yes, sasa we have data and is timely reported and completeness. Lakini je, data ziko pale, nani anazitumia? Unakuta kila mmoja akitaka ndo anaenda kutumia. Lakini kama PORALG tumeona sasa umefika wakati takwimu tunazo, and still we are still collecting the data, na ziko timely and completed, but how can we use data for decision making, for planning na mambo mengine. Kwa hiyo kikubwa hapa hatujaja na kitu kipya, ila tuna strengthen the system to work and to use their data ambazo tumezikolekti sisi wenyewe. Mwisho wa siku serikali kama serikali yenyewe iweze kutembea kwa miguu yake kutumia takwimu kwa ajili ya kufanya maamuzi. Kwa hiyo wito wetu na wadau mbalimbali mlioko hapa, tuziangalie system tulizo nazo at all level, from the facility, CHMT, RHMT up to national level, to use our data. Asanteni.
Thank you very much. A round of applause for the presenters. Asante sana. So that was PORAG Guest Forum. So we've taken some of your comments, and I understand that some of the questions probably were not answered in detail because of the time, but they are here. So after this session, you can just meet them and discuss further. There was an issue of digitalizations. Yesterday we had here at PORAG Health Forum. It's something that needs more investment. The community health digital part of the community is highly fragmented. That is true. So we are doing also with some colleagues, I see there, Simon, kind of a comprehensive assessment to see what is happening to our community systems in terms of all available digital platform. And then you can see how we can harmonize that part. So another thing that was mentioned, you mentioned about the digital also, digitalization in primary care facilities. That is an area that we are heading towards. So we have the government of Tanzania, Hospital Management Information System. So there's a very massive investment on that one. So the future is probably bright after we have been able to digitalize all the primary healthcare facilities. So we have a lot of individuals that we are partners on that endeavor, including PATH and others. So probably in the futures, we can be able to digitalize. There's digitalization and digitization. So I'm mixing up. But what I'm saying, we are going to have a digital in all of our facilities. So thank you very much for your time. A round of applause for all of us now. Asante sana. So I'm told that now we can go direct to Ruaha. So the guest of Hannah has already arrived for closure ceremony. Asante sana.